in kids. And we've got a great speaker with Dr. Kathleen Schwarz with Rady Children's Hospital, San Diego. And Dr. Schwarz also serves on our Medical Advisory Council and is a fantastic leader in all things pediatrics liver disease. And we just love having her involved. Also, we've got some great folks included for tonight's roundtable, and they'll be piping in and asking questions and really sharing this time with Dr. Schwarz as we go through and learn about hepatitis in kids. So with that, I would like to turn the screen over to Dr. Schwarz.
I can't share the screen.
Okay.
Because we're looking at yours.
Oh, I just gave you the permission there. Sorry about that.
Okay, that's all right. So welcome everyone to the alphabet soup of viral hepatitis in kids. And if you have questions as we go along, please do feel free to interrupt me. I am currently a pediatric hepatologist at UCSD and Rady Children's. And this is actually my last month in the Johns Hopkins Children's Center faculty as well, and from Baltimore, where I've been for the last 34 years. So it's great to be in California talking to you about viral hepatitis in kids. I have no relevant disclosures. I am the chairman of the pediatric committee of the Hepatitis B Research Network, which is funded by NIH. And I'm involved with the pediatric TAF trial for children with hepatitis B and some other non-viral hepatitis pediatric studies. So the objectives of my talk today, I do hope that you will learn the various viral etiologies of fulminant hepatitis and understand our recommendations for hepatitis A vaccine, know whom to screen for hepatitis E and the clinical manifestations, understand the recommendations for hepatitis B vaccine, for screening for hepatitis C, as well as screening for hepatitis B. And finally, we'll say a little bit about COVID-19 and the liver. So viral hepatitis is really an alphabet soup, and hepatitis A is probably the virus that's been known for the longest. E is a more recent newcomer, and F is for fulminant hepatitis. Hepatitis B, the most common cause of liver cancer in the world, and then hepatitis D, which needs the coat of hepatitis B to replicate. Hepatitis C, which now stands for both hepatitis C and for COVID. So we'll first talk about fulminant viral hepatitis, which means hepatitis with hepatic encephalopathy and coagulopathy. We'll talk about acute viral hepatitis. This is hepatitis A and E. The chronic viral hepatitides, which are hepatitis B along with D, and then hepatitis C, and then mention COVID-19. However, this slide is a slide from the World Health Organization, which talks about a brand new problem of viral hepatitis in kids. And that is something that has only been described for the last couple of months. There's very little written on it except in online sources. And the unusual thing about these cases is that they seem to be occurring in young children who don't have any underlying disease. And there are now, this is a map of the prevalence of viral hepatitis in kids, with the dark blue being in UK. This map is at the end of April, so it keeps getting updated. But now there have been about 200 children around the world who have been diagnosed with markedly elevated liver enzymes. At least half of them test positive for adenovirus 41, but there are other viruses that have also been implicated. And while most children have actually resolved their hepatitis, there have been 2 deaths, and there have been several children who needed urgent liver transplant. So it's definitely an ongoing picture. Now, this is a graph from our pediatric acute liver failure study. And these were several hundred children in North America who presented with acute liver failure, fulminant hepatitis, meaning that they had encephalopathy and or coagulopathy. Half of them were unknown. The most common cause was APAP or acetaminophen. And then there were scattering of these other etiologies. In contrast, this was an adult study, and by far the largest chunk of adults had acute liver failure from acetaminophen. About 25% were unknown, and then not seen in the pediatric data, there was acute liver failure of pregnancy, and there was some drug hepatitis. So if a child presents with rapidly rising liver enzymes and coagulopathy, we recommend that herpes be looked for, and that acyclovir be started while the diagnostic studies are being sent off. We also, of course, believe that hepatitis A, B, and E should be looked for, as well as EBV virus. And in newborns, you want to make sure that maternal hepatitis B serology has been checked. And if it's positive, then of course the newborn has to be screened for hepatitis B. And enterovirus can cause fulminant hepatitis in newborns. And of course, if viral infection is suspected, then adenovirus, especially 41, herpes, parvo, and influenza should be looked for. This is a map of the distribution of hepatitis A, and you can see that it is most common in South America, Africa, India, and Asia. But this hepatitis A, of course, is a vaccine preventable disease. So we're hoping that the incidence is falling. It's a very simple viral structure. This is the capsid of the virus. And there are foodborne outbreaks, Chilean strawberries, KFC, were a rather notorious hepatitis A outbreak. White Castle was another source of hepatitis A, and it's a highly contagious viral liver infection, but it is preventable by vaccine. It is fecal oral by transmission. It may last weeks for up to months, and the typical symptoms are jaundice, nausea, abdominal pain, and it's spread by direct contact or infected food or contaminated sewage. If one looks at various tests for hepatitis A, the virus circulates in the bloodstream before the symptoms begin. Then the virus is shed in the stool. Then the liver enzymes are elevated. IgM, anti-hepatitis A, rises, and then it falls, and the IgG, anti-hepatitis A, rises. Most people who have hepatitis A undergo spontaneous remission, but a few have prolonged jaundice, a few have relapsing hepatitis, and less than 1% can have a fulminant course.
So
And
Dr. Schwarz, I'm
yes,
wondering, like in San Diego, when we had the hepatitis A outbreak, and it had happened in different cities across the country, really targeting adults, but the homeless population. But we
right.
see more and more children that are homeless as well. Did you notice anything during that outbreak with children, in that hepatitis outbreak impacting children differently than normally how hepatitis A would impact them?
Well, that's a great question, Scott. I have not actually seen data on hepatitis A in homeless children, although, of course, they're not studied very carefully, and also they're not vaccinated. So I'm sure there were cases, we just didn't see them. But this is a powerful demonstration of the impact of hepatitis A vaccine, which was introduced in the late 90s. And as you can see, the incidence of acute hepatitis cases per year fell quite dramatically after the vaccine was widely used. There are 2 single antigens inactivated hepatitis A vaccines that are available, and they are 95% effective. And then this is just a sheet from the Red Book of the American Academy of Pediatrics that lists various recommendations for both the hepatitis A vaccine and for immune globulin for both post-exposure prophylaxis and then pre-exposure protection, particularly if one has children that are traveling to endemic areas. So hepatitis E is in many ways quite a bit like hepatitis A. This is the global distribution of hepatitis E. And you can see we do have it in North America, although it's mostly in animals. And it's most common in Sub-Saharan Africa, India, and Asia. It too is a RNA virus structure not unlike hepatitis A with the capsid and then RNA. And it too is spread by contaminated sewage, waters where open defecation is the practice, and refugee camps following floods. So it is very much like hepatitis A. And there is vertical transmission. So babies can acquire hepatitis E from their mothers, and then it's carried by pigs. So I actually wrote a paper with an Italian medical student about an area of Italy where hepatitis E was very common because Chingali or wild boar was quite a delicacy there, and unfortunately gave many of the people who consumed hepatitis E. So this is a diagram of the symptomatic cases of hepatitis E and the asymptomatic cases. And you can see that acute hepatitis with jaundice is actually just a small number of the cases. Liver transplant patients can get chronic infection with hepatitis E. Drug-induced injury can synergize with hepatitis E. Rarely there can be a neurologic injury. So most hepatitis E infections are clinically silent. The incubation can be up to 2 months, and the actual symptoms or jaundice may last days to several weeks, and most cases are self-limited. However, it is notorious for causing up to a 20% fatality in pregnant women, and the mechanism by which that happens is still not quite clear. And this graph looks a lot like the graph for hepatitis A. So you have virus in the stool shown by the brown line, and it is shed before the symptoms begin. And then the ALT rises, the IgM rises and falls, and the IgG rises. So there is a hepatitis E vaccine, but it is only available in China right now. So this graph just shows that injections of the vaccine do result in high antibody titers, and they last for up to 720 days after giving the vaccine. And we do hope that we will someday soon have hepatitis E vaccine available for use all over the world.
Did I understand, Dr. Schwarz, the slide where you said how it progresses and then it's in the stool and then the previous one? Yeah. So at the beginning, it's not in the stool, it's just in the blood, or where is it at until it?
No, I think it's the brown line is for the virus in the stool.
Gotcha.
I'm
okay.
sorry.
No, this is like the incubation period, weeks after exposure.
I'm sorry. The brown line is actually the liver enzyme.
Okay.
So the virus, so I guess first the liver enzymes start to rise, and then the virus would be detectable in the stool.
Gotcha. Okay.
And then, but the virus is in the stool before the symptoms happen, which are up here.
Gotcha. Okay. Thank you.
And just like with hepatitis A, both with A and E, the virus is shed in the stool and can be transmitted to others before the symptoms happen. The symptoms of jaundice and nausea and vomiting. So that's why both A and E can be spread fairly rapidly. So this is a graph of what is happening with acute hepatitis E. So there is RNA, which is the virus itself, that circulates in the blood and then is cleared in most people. But in immunosuppressed people, such as transplant patients, it can cause chronic infection. So the management is to reduce immunosuppression, and hopefully the HEV RNA will fall. If it doesn't fall with reducing immunosuppression, then ribavirin will usually control the virus. So now we're on to hepatitis B, the most common cause of liver cancer in the world. And this is a map of the distribution of hepatitis B surface antigen. So Northern South America, Sub-Saharan Africa, India, and Asia are the hotspots for this virus, although it is found all over the world. This virus is a different chemical structure than hepatitis A and E, which are RNA viruses. So this virus is a DNA virus, has a capsid, and the capsid is what is used to make the vaccine, but the DNA will get into the host DNA and replicate. So it's very hard to get rid of this virus. There are effective agents that control it, but right now we still don't have antiviral agents that will get rid of hepatitis B. Hepatitis B is in blood products, although our blood products are screened, so we really shouldn't be getting hepatitis B from blood products. It's in body fluids and it is sexually transmitted. It can be transmitted through transplanted organs. And of course, in pediatrics, mother to baby transmission is the most common route. And hepatitis B goes from acute infection to chronic infection. And unfortunately, and this is unique to pediatrics, about 90% of babies who acquire hepatitis B from their mother go on to chronic infection. Whereas the opposite is true in adults. Only about 5% of infected immunocompetent adults progress to chronic liver disease. So this graph shows the differences between adults and kids. So at birth, the rate of chronic infection for babies who acquire hepatitis B from their mother is very high. And then if children acquire hepatitis B during childhood, like a year of age or even older, then the chance that these infected children will have chronic infection is lower. On the other hand, in kids, symptomatic infection is not very common, and it becomes more common as the child ages. And this graph makes me very sad because in the North America, we have probably 1.4 to 2 million cases of hepatitis B, but less than half of those subjects are aware of their infection. Most are potentially available for treatment, but only about half actually enter into care, and only 50,000 actually get prescribed hepatitis B drugs. Up to 2 million infected individuals and only 50,000 being treated, to me, is a very sad set of numbers. So the Institute of Medicine has tried to address why aren't we treating more of these patients with this cancer-causing virus? And they're probably lack of public awareness, lack of provider awareness, lack of public resource allocation, and it all goes to high rates of untreated individuals. So who should be screened for hepatitis B? Well, people that have an increased hepatitis B prevalence when they come from regions with high or intermediate prevalence. And it's interesting, in our NIH-funded hepatitis B study, 95% of the children who had hepatitis B, of the several hundred children that we cared for in this network, 95% had some relationship to endemic countries. Either half of them were either adopted from areas of high prevalence, or they were born to mothers in North America, but the mothers were from high prevalence. Hepatitis B should be screened in patients where exposure should be managed, such as all pregnant women. Hepatitis B should be screened for sources of nosocomial infections. So these are donors of blood and plasma and organs. And then for those who have increased risk of medical consequences, such as HIV positive persons. So who should be screened? Again, the pink areas are considered high prevalence. So it's very important for the caring physicians and nurses to figure out the country of origin if a patient has signs of hepatitis or even elevated liver enzymes. And all people coming from areas of high prevalence should be screened for hepatitis B. And
I'm curious, I'm sorry to interrupt. I'm curious about adoption agencies. You think of them being very thorough and comprehensive, and there's no really mandate across the board of here's the things that we do, and on there is we screen the newborn for hepatitis B.
Well, that is a great question, Scott. And unfortunately, I have cared for many international adoptees in whom the tests in the country of origin were supposedly negative for hepatitis B. And then they're seen in adoption agencies in North America, and they're found to be hepatitis B positive, where sometimes the parents adopt them and only a good pediatrician will realize that the child is from China or another country, an African child, and screen the child that was supposedly negative for hepatitis B and find that the child in fact is positive. So thank you for asking. So the screening tests that we do are the surface antigen, the E antigen, and then these antibodies. And then for the presence of the virus itself, it's the hepatitis B DNA. So this is a graph that shows acute hepatitis B with recovery, typical serologic course. The E antigen is positive first for the first 12 weeks or so, and then converts to E antibody. In patients that resolve, like most adults, surface antigen becomes positive and then negative. The IgM anti-core antibody is detected. And then finally, in those that recover, there will be anti-hepatitis B, E antibodies, total anti-core, and anti-surface antibody. In the contrast, for patients that go to chronic hepatitis B, the E antigen will be positive for many, many weeks. It may convert to E antibody, but the surface antigen remains positive. So there are a variety of child-specific issues when it comes to hepatitis B. All pregnant women should be screened for hepatitis B. And now, within the last couple of years, there have been an increasing number of reports of pregnant women successfully treated during the third trimester for hepatitis B with reduction of transmission of hepatitis B to the offspring. Any newborn should be screened for hepatitis B, and newborns that are born to infected women should be given both active hepatitis B vaccine and antibody within 12 hours of birth. It is okay for hepatitis B infected mothers to breastfeed as long as there are no cracked or bleeding nipples. The child with hepatitis B should be allowed to go to school. So there's a lot of stigma about viral hepatitis. And I have written a number of letters to school authorities stating that the child with hepatitis B should be allowed in school. If the children are going to be immunosuppressed for cancer treatment or some other reason, then all children who are going to be immunosuppressed should be screened for hepatitis B because they should receive treatment while they're being immunosuppressed. Children and their parents are not required to tell their hepatitis B status. And again, there's a big stigma problem with hepatitis B. So I always counsel parents that they can keep the matter private. And then, of course, the child with hepatitis B should be monitored. So patients that are positive for hepatitis B, sexual contact should be vaccinated, barrier protection should be used during sexual intercourse, there shouldn't be sharing of toothbrushes or razors, and open cuts and scratches should be covered. blood spills should be cleaned with detergent or bleach. It's interesting that 10% bleach will kill any virus, including HIV and hepatitis B. So I always tell families that. Obviously, somebody with hepatitis B can't be a donor of blood or organs. And very important to immunize infants of hepatitis B positive mothers within 12 hours of birth. And children with hepatitis B should be able to participate in all activities, and they should be able to share food and utensils. They should be able to kiss people, but they should not be excluded from daycare or school, and they should not be isolated from other children, because this is really a blood-borne virus. And Mei Wei Chan in Taiwan has done wonderful studies showing that the impact of hepatitis B vaccine on the rate of childhood liver cancer, because you can see that since 1982, when high-risk infant immunization was initiated, and then 1986, routine infant immunization was initiated, and there was a dramatic fall in the rate of hepatocellular carcinoma. There are a number of treatments for children with a hepatitis B. Alpha interferon and pegylated interferon are effective, but not particularly well tolerated. Lamivudine and adefovir are used in some parts of the world, but they're high resistance rates. So we generally are not using those in North America, where we have both entecavir and tenofovir, which are approved for down to 2-year-olds. So the hepatitis C virus was described in 1989, and we have Rick Janish in our panel, who has his own personal story to tell about hepatitis C. Do you want to speak, Rick?
Yeah, sure. Thank you. So I was actually, I was diagnosed with hepatitis C when I was 12 years old, actually at Rady Children's Hospital. And you know, it's unusual for a 12-year-old to have hepatitis C, and especially in 1999 when I was diagnosed. And you know, they checked my family and they found out my mom was the source, and so that's how we found out I was a vertical transmission, which is somewhat rare, quite rare now, regarding transmission for hepatitis C, as I'm sure we'll get to. But for me and my family went through 3 different treatments. My mom went through 3 different treatments and was eventually cured in 2011. I was not so lucky. I had a variant strain, and for me, it actually took a grand total of 6 different treatments. I went through 3 of the older ones, the interferon ribavirin treatments, and then I went on to go into end-stage liver disease and experience all the myriad of symptoms that we're about to go into. And it was very challenging to go through those times. But in 2016, I successfully received a liver transplant. And then 2017, I went on a unique combination therapy of Zepatier, Sovaldi, and ribavirin. And then once that course was completed in September of 20, received news that I was cured of hepatitis, or had my SVR, sustained viral response, of 24 weeks. And that means I'm pretty much good to go with hepatitis C, and I was fundamentally cured. And so now I am a lot healthier, and it's nice to be alive and and kicking. But yeah, no, it was quite a challenge going through all those years.
Well, and you look just great. So
thank you.
Dr. Schwarz,
a wonderful story.
Yeah, Rick mentioned something about vertical transmission for hepatitis C and that it was rare. And I think I overheard you speaking with someone about now with the opioid epidemic, that we're seeing many more babies where there's vertical transmission. Did I mishear something?
That's true. And you just led into my next few slides. Thank you. So this is the 2020 data for the number of hepatitis C infected adults worldwide. And you see Russia, former Soviet Union, has the highest prevalence, and so does Egypt. There are 3 million kids roughly in the world with hepatitis C. So the exciting thing is that we finally have therapeutic agents that are safe and highly effective and don't even require a liver biopsy for treatment. So this is a slide of hepatitis C infection in adults. About 2/3 acquire hepatitis C via injection drug use. There is some sexual transfusion. We used to have bloodborne hepatitis C transmission. That's very rare now that we have screening. And then there is some healthcare workers, and the perinatal transmission is about 5%.
I have a question on some of those
Yes.
I remember like looking back at some like past data that they've looked at, because I've seen this kind of referenced a lot, but I've also heard that, you know, when it comes to the birth cohort, basically the boomer population that has hepatitis C, that there was a lot of conversation that, there were a lot potentially more medical sources, and that, the use of air guns also could have correlated with a lot of high use of transmission and things like that. How does that fit overall?
Well, I think the highest risk transmission is still injection drug use.
I mean, currently, yes. I'm with you.
We're in the midst of an opioid epidemic, and that's why we're seeing this fairly dramatic rise in newborns with hepatitis C. So hepatitis C, and Rick, you described your course. This is probably what happens to you: acute infection, and then chronic, and then fibrosis and cirrhosis, and hopefully no cancer for you.
I was close. I had like 4 or 5 precancerous nodules that actually comprised most of my liver by the time they transplanted out.
Wow.
Yeah.
Well, looking at you, you never know anything happens, which is the way you're supposed to look. So this is what we recommend screening for hepatitis C. If the antibody is non-reactive, then one can stop. If the antibody is reactive, it still is not a test for the active virus. So it's the RNA, the ribonucleic acid, that is the active infection. And if it's detected, then and is detected over a 6-month period, then this is consistent with chronic infection. So in kids who are born to hepatitis C positive mothers, about the earliest that screening is indicated is 2 months of age. But then we have to use the RNA, the virus test, because the maternal antibody lasts for up to 18 months. So we don't do the antibody testing, which is cheaper than the RNA testing, until the baby's 18 months of age. And we don't have treatments until 3 years of age. But this is what Scott was talking about. And this triangle is the age 20 to 29. And there has just been this dramatic increase in acute hepatitis C in the last decade, both in the 20 to 29-year-olds and the 30 to 39-year-olds. And it is thought that this is related to the opioid epidemic. And here, Scott, is what you asked me about: the number of US live births affected by hepatitis C during perinatal transmission. This is 2013 and 2017, so it's more than doubled during those last several years. And again, it's the opioid crisis. And the amazing thing is we do have several safe and effective regimens for hepatitis C in kids. And the approval is now down to age 3. And the various preparations are available in either tablets or little tiny pellets that a 3-year-old could take. So to go from the story that we heard from Rick, which is an awful story, but with a happy ending, chronic liver disease and the need for transplant, to treating a 3-year-old for 12 weeks and sending a normal child that's virus-free to kindergarten. That's just very, very exciting. And this is my last slide. We all know what this virus looks like. We've seen COVID too many times. And our North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition is collecting data on COVID cases in kids who haven't had a liver transplant but have some kind of liver disease, or those who have a transplant. And this is an ongoing registry, but COVID does get into the liver. I guess the best thing you can say is that our kids who've had liver transplants do not seem to have any increased severity of COVID hepatitis. But nonetheless, it's not anything that you want in your liver. So the soup says, I have no clue what you're trying to say. You keep giving me mixed messages because there are too many viruses, too many letters. So we have to keep working on screening for hepatitis B and C and treating children who have those viruses, immunizing for hepatitis A, hoping that we will have a hepatitis E vaccine pretty soon, and of course, vaccinating against COVID. Any questions?
The screening recommendations for hepatitis C.
Yes. So, of course, the baby boomers are all supposed to be screened, and all pregnant women are supposed to be screened. We have tried to get recommendations for screening children because, again, we have these highly safe and effective treatments, but we haven't succeeded in getting those recommendations.
Yeah.
However, if a mother has hepatitis C, the infant is supposed to be screened. That is a bona fide recommendation.
Yeah, that's on the CDC, but not the USPSTF, if memory serves.
Right.
Yeah, because the CDC's came out about 6 months later, and they were like, "Oh yeah, maybe we should add that. Maybe that's important." You know,
and
a lot of advocates.
We wrote strongly worded letters to try to get broader recommendations for screening kids.
Believe me, I was right on it. I wrote a HepMag article.
I know how to spell your name. I know.
Yep. Yep.
Can you talk a little bit about the registries? So there's like a cancer registry that people talk about, and hepatitis C, they're trying to create like a hepatitis C registry. But you talked about the confidentiality and not having to disclose. What is a registry? And is that there's no identifying information on it, so no one, it's still private, it's just a way to track the numbers? Or how does that deal with hepatitis B and C?
I am, in terms of hepatitis B, we have this, there is no registry of hepatitis B cases that I know about. As I said, I am in the NIH funded hepatitis B consortium, And that is just now coming to a close, but it is in its 12th year.
Mhm.
So we have about 2,000 adults and about 400 some kids. And of course, the patients sign informed consent, but part of their informed consent says that their data will be barcoded.
Right.
There will be no private information. And I can speak to the large populations of hepatitis C in children. I was involved with the first randomized controlled trial for kids with hepatitis C. And again, that was funded by industry and NIH. And the same thing true with hepatitis B and hepatitis C, because it's funded by the NIH. There are biological samples and data that are available for study by members from industry or individual investigators, but it's all barcoded, so it's all private.
Yeah, I think it's a public health, in the public health arena, they're looking at like, how do we find out where the cases are? What are the behaviors? How is it spreading, so they can really focus resources? But public health doesn't own everyone's health. We have our own private health care. And
Right.
so my guess is that there's going to be some conflicts as there's discussions about registries for hepatitis C, so we can really track that care continuum and see how many people got treatment and how many people, we just may not ever know those numbers because of confidentiality.
Right. Now, one of the innovations in screening that I mentioned to you earlier this week, Scott. So we have neighborhood health clinics in San Diego where Jeannie Wang, who's a pediatric gastroenterologist at Rady, has worked with Dr. Gish and Christian Ramers to put a notice to the practitioners in every EPIC chart as a reminder to screen all these children for hepatitis B and hepatitis C, because by virtue of the fact that they're in a neighborhood health clinic, they are in a very low socioeconomic status. And we have a hepatitis B prevalence rate of 5%. We're just presenting that at AASLD. So that's that. If you look at papers on cost effectiveness of screening, rates that are like 0.5% are considered cost effective. So right here in San Diego, to have a 5% screening rate for hepatitis B was quite something.
Well, thank you so much, Dr. Schwarz, for being here and talking about hepatitis in kids. I think it was a great discussion. I learned a lot because we just kind of see all the adult stuff. And I never really saw it through a child's eye. So thank you for that. Any questions? Yes. A closing question, Rick?
Yeah, actually, because I having had being diagnosed with hepatitis C while I went to school, we disclosed that fact to the school, which turns out bad idea. Don't do that. So I was excluded from contact sports, actually all sports in general. They were just like, let's just not take the risk. And so that was interesting. But it also ended up affecting relationships with teachers, with everything, with everybody there. 'Cause stigma is huge with viral hepatitis, regardless kind of which one you're looking at. Liver disease, I think in general, carries its own kind of unique weight of deservedness and confusing things like that. But it was very interesting seeing, what you said regarding hepatitis B, because again, it is much more commonly vertical transmission. So you're going to see a lot more kids, with that. But seeing that there, I was like, nah, dude, I wish people would tell that to people. How would you kind of advise, maybe some parents who are, who have a child who has viral hepatitis, who, is trying to figure out what to do at school because maybe they want to get them on treatment. Maybe they're like their teens or something and they're trying to find the right time. What would you suggest they do regarding the information in terms of telling people and then maybe timing that type of thing?
Well, it's an excellent question without easy answers, because I think we all have a slightly individual approach since there really are no firm policies. But my general guidance to families is just as you say, there is a lot of stigma associated with both hepatitis B and with hepatitis C. And I think we hepatologists should take a lesson from the HIV community, because I think they've done a much better job of being proactive on behalf of their patients. So what I tell families is that as far as we understand, there is no legal requirement to disclose the hepatitis B or hepatitis C positive status. I do say that, unfortunately, school personnel are supposed to use universal precautions. They don't. So coaches and teachers don't use universal precautions. And so if a child with hepatitis B or C has a skinned knee and the coach or the teacher or the nurse goes to help the child, they may well not do what they're supposed to do, which is to use universal precautions. So I think as is disclosure of anything that's intimate and personal, a lot depends on the personal relationship that the family has with the coach or the babysitter. And while there are no legal requirements for disclosure, what I generally counsel families is that, look, if you've got a great relationship with your babysitter or your coach, people that are likely to come in contact with the child's blood, you probably will want to disclose, but you're not required. And then the other part of me says, well, if a babysitter acquired hepatitis B or C from a child, what are the her legal rights or his legal rights? And, could he or she sue the family for not disclosing the status? And I don't think that that's completely worked out. So
I've seen some case briefs because I've looked into all this because, being in the situation, you got to look out. Plus, I also worked at a school district for a while as well.
Okay.
So there are some legal situations regarding that, but for the most part, unless there's intent and unless there's some sort of very, very some sort of malicious intent and some sort of, very intentional exposure, generally speaking, it's been a sort of a very accident kind of going okay, this isn't anyone's fault.
Right.
And generally speaking, cases have said, no, this isn't their specific fault. So just wanted to.
Interesting. Thank you.
Definitely lots of opportunities for engagement. I think you're right, Dr. Schwarz. We can look to the community that really stood up first for HIV and fought for rights and continue to do so. So I think we've got a good roadmap in that community on how we might approach this one as well. Well, thank you so much.
I have a patient who is a star athlete. Who's being recruited by colleges and universities. And the question is, should that person reveal the hepatitis B positive status? And I went all the way to Dr. Hoofnagel, head of the NIH liver unit, and several other international authorities asking about the legality, and it wasn't clear.
Wow.
So
Very
I
interesting.
think we have some work to do.
Yeah. Well, thank you so much, everyone, for being here, and Dr. Schwarz for leading the discussion.
Yes.
And that wraps it up. And have a great evening.
Thank you.
Okay.
Bye
Thank
now.
you. Thank you all.
Yes.
Bye.